Imagine going through like a really complex, deeply painful reconstructive surgery. You endure the recovery, you wait for the stitches to dissolve, and then in this attempt to speed up your healing and get the best possible result, you inadvertently melt your own surgically repaired tissue.
God, I mean, it sounds like an absolute horror story. But in the rapidly expanding and honestly kind of poorly regulated world of post-op aesthetic treatments, this scenario is playing out far too often.
Yeah, it really is. And, if you were navigating the aftermath of pelvic surgery or even just like looking into your options, you probably already know how totally murky the recovery guidelines can be.
Oh, absolutely.
We're just constantly bombarded with marketing for these add-on treatments.
Yeah.
So today on the Deep Dive, we are unpacking a really major dilemma in the world of pelvic health and medical aesthetics. We're talking about vaginal reconstructive surgeries.
Right. So things like prolapse repairs, vaginoplasties, or, labiaplasties.
Exactly. These are major anatomical structural renovations.
Right.
But what happens when a patient, or honestly a very persuasive clinic, wants to add finishing touches to the mix? I mean, things like localized energy devices, fractional lasers, radiofrequency, or cosmetic injectables.
Yeah, the problem we're seeing right now is that the marketing for these devices moves, well, a lot faster than the biological reality of human healing.
So much faster.
Right. And the technologies are becoming incredibly accessible, which, is great in theory, but they're being sold as these package deals without any regard for the chronological steps the body actually has to take to repair a surgical wound.
Which is exactly our mission for this deep dive. We are going to cut through that aggressive marketing. We want to establish the exact, non-negotiable biological and chronological healing benchmarks required after a major vaginal reconstructive surgery.
Basically, what needs to happen before you can safely introduce these localized treatments?
Exactly. And we're pulling from a really fascinating stack of source material today, including clinical trials, surgical guidelines from bodies like NICE, and some really comprehensive technology overviews.
Yeah, and to set the baseline for you as we get into this, the foundational rule is simply that you cannot treat all post-op add-ons as if they do the same thing.
Right. They're not a monolith.
No, not at all. Some of these interventions are biologically designed to, actively assist your cells in healing, but others rely on a mechanism of controlled damage. And if you introduce them too early, well, they will actively destroy a highly fragile healing process.
Okay, so let's start at the very beginning of the timeline then, the immediate aftermath.
Yep.
Our sources point to the first major biological benchmark, which basically covers weeks 1 through 8 immediately following surgery.
Yes, the wet drywall phase.
Right. This period requires something the medical literature calls epithelial closure before you can even entertain the idea of secondary cosmetic or structural interventions.
And we really have to look at the sheer depth of the tissue involved to understand why that closure is so critical. I mean, a vaginal reconstructive surgery is not a superficial scratch.
Right, it's not of the paper cut.
Exactly. The surgeon is creating wounds that penetrate deep beneath the surface layer. They're cutting into the basement membrane, the vaginal mucosa, and the underlying connective tissue.
Okay, let's actually define some of that anatomy for our listener because it's super important here. The basement membrane, for instance. That's essentially the thin, dense layer of tissue that acts like the biological glue holding your surface cells to the deeper structural layers, right?
Yeah, that is a perfect way to visualize it. It's the foundation. And when a surgeon cuts through that foundation, the first non-negotiable benchmark your body has to achieve is epithelialization.
Right.
Which is just the biological process of the skin or the mucosa knitting itself back together and sealing the surface to the outside world. Because until that happens, your internal structures are entirely exposed.
And the timelines in our sources are, quite rigid about this. For standard surgical incisions, like what you might see in the localized labiaplasty, it takes a solid 4 to 6 weeks for that tissue to close and build any real tensile strength.
Oh, right. And that timeline pushes out even further for more complex reconstructions.
Oh, really? Like what?
Well, if we look at advanced reconstructive surgeries, particularly those augmented with human amniotic membrane, which is often abbreviated as HAM, surgeons use it as a sort of biological dressing to support tissue regeneration. For those, the targeted window for normal epithelialization is anywhere from 4 to 8 weeks post-op.
Which honestly brings up a really common trap that patients fall into. The sources note that the stitches themselves usually dissolve in 2 to 3 weeks.
Yes.
So I can completely imagine a patient seeing that a stitch has fallen out and thinking, great, the stitches are gone, my skin looks closed, I must be fully healed and ready for my laser treatment.
And that visual trap is incredibly dangerous. because the surface appearance absolutely does not reflect the internal reality. Just because the external sutures have dissolved or, the topmost layer of skin looks somewhat flat, does not mean the internal tissue matrix is fully stabilized.
Right, it's basically an illusion.
Completely. The newly formed tissue is incredibly weak at that stage.
It's like attempting to power wash a newly built brick wall, while the mortar between the bricks is still wet sand. Like, you might see the bricks stacked up, but the second you apply external pressure, the whole structure just blows apart.
That is exactly it. And this is exactly why the basic physical benchmarks are so unapologetically strict.
Right.
The clinical guidelines universally restrict intercourse and even basic tampon use for a minimum of 6 to 8 weeks.
Because the barrier function is completely compromised.
Right. And furthermore, we have to consider the starting point of the tissue, too.
What do you mean?
Well, if a patient was using a pessary device to manage an organ prolapse prior to their surgery, they often go into the operating room with baseline ulcerations or excoriations.
Oh, basically raw, rubbed away areas of tissue.
Exactly. And those require ample time to heal on top of the surgical incisions. If the surface isn't fully sealed, the tissue cannot defend itself against the invasive mechanisms of secondary treatments.
Okay, so establishing surface integrity by week 8 is benchmark number 1. The wet mortar needs to cure. But looking through the sources, there's a glaring contradiction here that we really need to unpack.
Let's hear it.
The guidelines are screaming at us to leave the tissue alone, right? But then we see this massive exception made for PRP, or platelet-rich plasma.
Yeah.
PRP seems to bypass this waiting period entirely and is actually integrated right into the immediate healing timeline. Like, why?
Yeah, it's true. PRP is the ultimate anomaly in the post-op landscape because it acts as a healing accelerator. To understand why it gets a free pass, we have to isolate what it actually is. Unlike energy devices that operate by creating trauma, PRP is a concentration of growth factors harvested directly from your own blood, spun down in a centrifuge, and used to dramatically speed up tissue repair.
And the clinical evidence here is wild. Like, there's a 2017 case series on aesthetic labial procedures that details how surgeons are administering PRP intraoperatively.
Yes.
Meaning, while the patient is still on the operating table, right after the surgeon finishes trimming and suturing the tissue, they are injecting PRP directly into the raw wound.
Exactly. Or they're applying it topically as a gel on fresh incisions, or even injecting it 1 to 2 weeks post-op. And the data shows it leads to a faster resolution of bruising, lower pain scores, and substantially stronger wound healing.
But wait, this doesn't track logically when you compare it to the rules for other injectables? The sources, specifically the Trambolier Clinic guidelines, are very explicit that hyaluronic acid, or HA, which is, a hugely popular injectable used for vaginal dryness and plumping, is strictly contraindicated if there is active inflammation or recent surgery. So why is HA entirely banned from this immediate post-op window, but PRP is aggressively utilized? They are both injectables.
It's a great question, but the contradiction disappears when you look at the biological mechanism of each substance. Hyaluronic acid is a volumizer. It's essentially a space-occupying sugar gel.
Yeah.
For HA to function properly and look natural, it requires a stable, calm, uninflamed tissue bed to sit in.
And a fresh surgical site is the exact opposite of calm.
By definition, yes. A fresh surgical site is swollen, inflamed, and highly reactive. If you inject hyaluronic acid into that environment, the HA acts like a biological sponge.
Oh, wow.
Yeah, it aggressively draws in surrounding water, which massively exacerbates the swelling. That excess pressure from the swelling can literally pull your newly placed incisions apart.
Oh my God. So injecting HA into an inflamed surgical site is like pouring wet cement into a foundation that is actively shifting due to an earthquake. It's going to ruin the structure.
That's a really great way to put it. It actively works against the healing process. PRP, however, relies on an entirely different biological pathway. PRP is an active biological messenger. It actually requires and utilizes the body's natural inflammatory phase to do its job.
Oh, so?
Well, when you inject PRP into a wound, the platelets degranulate.
Degranulate meaning like they break open and release their payload.
Yes, exactly. They break open and flood the local area with cytokines and growth factors.
And cytokines are basically the chemical distress signals the body uses to call for cellular backup.
Right. They are the directors of the inflammatory response. Those cytokines and growth factors instruct the surrounding cells to build new blood vessels and rapidly accelerate tissue repair. So if HA is the heavy, space-occupying furniture you can't bring into a house until it's finished.
PRP is the active construction crew.
Exactly. You want them there on day one while the framing is happening.
That distinction is so clarifying. Injectables are not a monolith. Regenerative treatments like PRP are safe and beneficial from day 0 to week 2. But structural volumizers like HA have to wait until the biological dust settles.
Perfectly said.
Which transitions us to the most critical and heavily marketed segment of our deep dive, the strict 6-month inflammatory roadblock for energy devices.
Yeah, this is where the marketing most aggressively ignores the biology, creating immense risk for the patient. We are talking about treatments using fractional CO2 lasers, ERYAG lasers, and radiofrequency or RF devices.
And to understand this benchmark, we have to look closely at Dr. Newat's research on the chronological phases of wound healing. According to this research, at 6 weeks post-operation, even though your surface tissue might look closed, you are still fundamentally trapped in the inflammatory phase.
Right.
It isn't until you hit the 6-month mark that the onset of remodeling and scarring even begins to stabilize, and the tissue doesn't reach its final surgical outcome until a full 12 months have passed.
And those lengthy timelines are non-negotiable because of how lasers actually interact with human tissue. Dr. Lauren Streicher, a gynecologist who extensively studies these treatments, points out in our sources that lasers are not magic wands. They operate on the principle of controlled thermal injury.
Right, they are burning you. Controlled, yes, but they are using heat to vaporize water in the tissue and create microscopic channels of damage.
They are purposefully traumatizing the tissue to trigger a panic response in the body, and the goal of that panic response is neocollagenesis.
Neocollagenesis being the body's emergency response to build fresh, tight, new collagen to heal the burn.
Yes. The body says, we've been injured, we need to send resources to rebuild this area thicker and stronger. That is the intended outcome of a laser.
Okay.
Now, look at the NICE guidelines, the National Institute for Health and Care Excellence. They conducted a massive overview of clinical trials for transvaginal laser therapy. In their criteria for who is even allowed to participate in these trials, they explicitly list pelvic surgery within 6 months as a strict exclusion criterion. Yeah, if you had surgery 5 months ago, you were banned from the trial.
Okay, but let me challenge that logic for a second, based on the mechanisms you just described. If a surgical incision triggers a massive healing response, and the laser triggers a massive healing response by creating a controlled burn, why wouldn't a clinic want to stack them?
I see where you're going.
Right, like why not do the laser right after the surgery to get a compounded, super healing collagen boost? Make the body work double time and get tighter tissue faster.
Biologically, it is catastrophic. It comes down to the concept of compounding inflammation and metabolic bandwidth. Your tissue only has a finite amount of cellular energy and blood supply available at any given time.
Okay.
A major reconstructive surgery maxes out that bandwidth. Hitting actively inflamed, surgically traumatized tissue with high levels of thermal energy is like pouring gasoline on a house fire, hoping it will put it out.
Oh, wow.
You aren't getting super healing. You are overwhelming the local cells, leading to tissue exhaustion and ultimately necrosis, where the tissue simply dies.
And the sources actually back this up with a highly specific cautionary case study. The NICE overview highlighted a patient who received a laser treatment and then subsequently required pelvic surgery a year later.
Yeah, and the outcomes of that case were alarming. When the surgeon went in to perform a posterior vaginal repair and place a mid-urethral sling, they documented that the patient's vaginal mucosa was very thin, friable, with loss of rugae.
Let's translate those clinical terms. Loss of rugae are the natural accordion-like elastic folds in the vaginal wall that allow it to expand and contract, right?
Exactly.
So the laser essentially ironed the tissue flat and made it rigid. And friable, meaning the tissue just crumbles or tears easily under pressure.
Yes. The tissue lost its structural integrity. It became brittle. Because of the previous thermal injury from the laser, the reconstructive procedure became incredibly difficult. The tissue wouldn't hold sutures properly, and it caused significantly higher blood loss for the patient.
Now reverse that timeline. Imagine taking tissue that is already friable, thin, and vulnerable from a fresh surgical incision, and then blasting it with a thermal laser before it has even finished its basic 12-month remodeling phase. The destruction would be massive.
It would.
You absolutely must wait a minimum of 6 months for the surgical inflammatory phase to completely clear before you even consider inducing a new wave of thermal inflammation.
Which naturally raises a dilemma for the patient. I mean, if you are suffering from severe vaginal dryness or atrophy, which is why many seek out lasers in the first place, and you have to wait 6 to 12 months after your prolapse repair to safely get that laser treatment, what are you supposed to do? You can't just suffer in discomfort for a year.
No, of course not. Which leads us to a really fascinating biological workaround detailed in our sources, the estrogen bridge. Local vaginal estrogen is highlighted as the vital prerequisite benchmark
Yeah.
used to ensure the tissue is actually robust enough to endure either the initial surgery or the delayed device treatments.
And the mechanisms of local estrogen are profound, specifically regarding connective tissue. A paper in our stack focusing on perioperative factors details how estrogens act on the estrogen receptor alpha, which is densely located in the vaginal epithelium.
Okay, so what does it do when it activates that receptor?
When applied, estrogen actively increases collagen and elastin synthesis. It regulates and increases local blood flow, and it dramatically improves epithelial hydration.
The data on how this is used as a preoperative benchmark is incredible too. Like research by Ron and colleagues demonstrated that applying topical estrogen for at least 4 weeks prior to surgery actively reduces degradative enzymes in the tissue.
And those degradative enzymes are essentially the body's internal demolition crew. Their job is to break down old or damaged tissue.
So by using estrogen to suppress that demolition crew, you are preventing the tissue from being broken down right where the surgeon is trying to work. Ron's research notes this quite literally makes it easier for the surgeon to place sutures because the tissue is thicker, more hydrated, and holds the stitch much better.
And the benefits don't stop in the operating room. Post-operative research by Karp and colleagues demonstrated that early intravaginal estrogen administration after pelvic reconstruction effectively improves a whole host of tissue quality markers.
So if you are a patient waiting out that grueling 6-month benchmark before you can safely get a laser treatment, local estrogen is your active rehabilitation. It's the fertilizer you use during that waiting period to ensure your tissue is thick, hydrated, and fully recovered.
Right.
That way, when the laser is finally applied at month 6 or month 12, the tissue has the biological bandwidth to actually withstand the thermal injury and respond by building new collagen rather than just breaking down and tearing.
Exactly. You are actively setting the biological stage for success instead of setting it for catastrophic failure.
Well, let's bring all of this complex biology together and recap the specific benchmarks we've extracted from the sources today. Because this timeline is the ultimate cheat sheet you need to protect yourself.
It really is. The sequence is everything.
All right, benchmark 1. You absolutely need 4 to 8 weeks for baseline epithelial closure. No tampons, no intercourse, no structural volumizing injectables like hyaluronic acid. You have to let the wet mortar dry and the surface seal.
Yep, non-negotiable.
Benchmark 2, the biological exception. Regenerative injectables like PRP can be utilized immediately in the operating room or within the first 2 weeks because they act as the biological construction crew utilizing the inflammation to heal.
Right. They use the fire instead of fighting it.
Exactly. Benchmark 3, the strict minimum of 6 months, and ideally up to 12 months, before you can safely introduce thermal injury devices like lasers or radiofrequency. You cannot compound inflammation or you risk tissue necrosis.
And finally, local estrogen is your crucial bridge before and after surgery to fertilize, hydrate, and prep the tissue for the trauma to come.
Yeah. When you lay the benchmarks out chronologically like that, it highlights exactly why understanding these cellular timelines is critical for anyone undergoing these procedures.
It is the only way to protect yourself. We know that in the lucrative world of medical aesthetics, aggressive marketing will often try to bypass these vital biological realities. Clinics want to sell you a comprehensive package deal today, not next year.
Right.
But knowing these timelines protects your long-term health, it protects your immense surgical investment, and it prevents you from inadvertently destroying the very tissue you just paid a surgeon to repair.
Absolutely.
Keeping all of this in mind, there is a final concept I want to leave you with, something to explore on your own that builds logically on everything we've dissected today.
Let's hear it.
We established that energy devices like lasers exist solely to create a controlled thermal trauma, which forces the body to panic and remodel its collagen. But we also just established that a major reconstructive surgery inherently forces the body into a massive 12-month collagen remodeling phase due to the surgical trauma itself.
So the surgery is already doing the heavy lifting.
Precisely. Which begs the question, does the biological reality of the surgical healing process completely negate the need for a laser at all?
Oh, wow. Think about it. If you actually wait the required 12 months for the surgically traumatized tissue to fully remodel, tighten, and heal itself, well, you might just find that the expensive laser treatment you were being sold is no longer necessary.
Because the house is already fully built, the walls are completely dry, and the body has already provided all the new collagen you were looking for.
It's a biological redundancy that aggressive marketing hopes you never figure out. That is a phenomenal point to consider the next time you see a 2-for-1 surgical and laser package being advertised. Thank you for diving deep into the biology with us today. Keep questioning the timelines, protect your healing process, and we will see you next time.